Very good afternoon, ladies and gentlemen. We, as Ophthalmological Society of West Bengal, feel extremely privileged and honored to have this session for the first time in AIOS conference, more so as it is in conjunction with APAO. And I am Dr. Sudipta Mitro, along with along with my co-moderator, Dr. Shubhashish Nagsar. We welcome warmly all of you in this session, which is designed as recent know-how to ace your cataract surgery in daily comorbidities. At the beginning, let me call upon our chairperson, Dr. Arup Chakraborty sir, who is also our president of OSWB. Dr. Partho Biswas sir is not here. He had to go for a award ceremony. I also welcome our vice chairperson, Dr. Rotish Pal sir. Sir, please come on dais. Our esteemed panelists are Dr. Shubhadra Jalali ma'am. Ma'am, if you can grace. Dr. Partho Prateep Datta Mujumdar sir. Dr. Anil Mondal sir. And Dr. Namrata ma'am, who's yet to reach us. From OSWB, we have Dr. Aniruddha Maiti, who is also our secretary. Dr. Amitabh Kumar, you may sit in the front row. Please come in front. Dr. Manish Singh, Dr. Arup Bhaumik, Dr. Arnab Mitro, and Dr. Shubhankar Home.
Okay. Thank you, Dr. Sudipta, for the brief introduction and beginning this program. Since we are already late by some few minutes, I would request our first speaker, who is Dr. Siddhartha Ghosh. Basically, the topic of this symposium is recent know-how to ace your cataract surgery in the patients with daily comorbidities. As you know, this is what we day in and day out we find in our OT list. So we will just go through them and how best to ace them to come out winners. Over to you, Dr. Siddhartha Ghosh. He will be speaking on avoiding hiccups in cataract surgery with associated inflammation. Dr. Siddhartha.
Slides, please. इसको हटा दे. आपके सिस्टम में भी रखा हुआ. Well, good afternoon. Thank you, Dr. Sudipta Mitra, for bringing in this important topic. And I am going to talk about managing uveitic cataracts. Well, managing uveitic cataract involves a multi-pronged approach, mainly focused on controlling inflammation, meticulous surgical technique, close monitoring for complications, and with the ultimate goal of improving vision. We all know that this prolonged inflammation in uveitic eyes leads to breakdown of the blood ocular barrier, and that leads to cataract formation. And many times using steroids for a very long time may also induce cataracts. Well, we need to focus on the pre-operative management, the surgical management, and the post-operative management in these cases. As for the preoperative management, controlling inflammation, the mainstay would be the medical therapy. And in certain situations, when the etiology is infective, we need to look at antibiotics and antivirals whenever required. And for example, in HSV1 or varicella zoster virus induced uveitis, we need to give full dose of antivirals maybe 7 days prior to the planned surgery, and thereafter we continue for at least 1 week prior to surgery, and then of course in a prophylactic dose later for about 4 weeks or so after the surgery. Now we need to ensure that the eye is quiet from any inflammation for quite some time, typically 3 months or more. And we need to carefully assess these patients. The presence of corneal opacities or maybe condensations or opacities in the vitreous, CME, cystoid macular edemas or macular scarring, or if there are any optic atrophy, these may limit the visual outcome of these patients. Well, as for the surgical management, for cataract surgery, phacoemulsification with IOL implantation is the method of choice, surgery of choice. And of course, the steroid coverage, we need to look at perioperative steroid coverage, and managing the pupillary issues are also important. As for the choice of IOL, uh, it will depend on the individual factors and the surgical techniques, but in general, the consensus is hydrophobic acrylic IOLs. There are many others which are also suitable, heparin-coated IOLs and others. But it will be case-to-case basis. The surgeon has to decide. There are many situations where in JIA, in young children, uh, earlier you used to avoid implanting lenses, but then after the advent of biologicals, the situation has changed. Of course, now let us look at a video of a typical surgery. Here what I show is I use a iris repositor, a band, blunt spatula just to break the posterior synechia, as you can see. And then the pupillary membrane it needs to be peeled off, not all at a time. You need to be meticulous so that there is no hemorrhage. There will be little hemorrhage, but we need to be very meticulous and remove the whole thing. And then we need to use multiple instruments, maybe 2 instruments to stretch the pupil so that it can accommodate a pupil expansion device. Any device of choice would do. And here I am just trying to implant a BX pupil expander, and whatever is available can be used. After that, once we have adequate pupillary exposure, because it's a white cataract, I am using little trypan blue to stain the capsule, and it's done under viscoelastic. You can see there is enough staining, and so we can proceed with a Rexis as usual. We need to remember in these cases the size should be adequate. So because uveitic cataracts, these patients are prone to developing capsular phimosis. The Rexis becomes small later on because of repeated inflammations. And the other procedures are similar. This is a soft cataract. So what we do here is, we do a quick phacoemulsification. It's a soft cataract, comes in flakes. What we need to remember is removing all pieces very meticulously, and we need to take out all the cortex as much as possible. We need to take special care to take out all the cortex. We don't want to leave anything behind, especially in these situations. And then uh, we implant a lens. In this case, a hydrophobic acrylic lens is being implanted. Once it's implanted, we make sure that it's definitely in the bag, and then we take out the pupil expansion device so that once it is taken out carefully, we take out all the viscoelastics from behind the IOL as well as from the AC. We need to be very meticulous in cleaning up all the viscoelastics, because again, all these factors will lead to recurrence of these uveitis. Now, post-operatively, the steroids and cycloplegics would be the mainstay. We need to closely monitor these patients for further recurrences and complications, and aggressive treatment for complications is very important. The key considerations here would be patient education, and we need to make people understand that you need a certain amount of expertise, surgical expertise, that is involved in doing these cases. And of course, these will result with patient cooperation. Thank you.
Thank you, Dr. Ghosh. I would request our panelist, the expert from inflammation, Dr. Parthopratim, to start the discussion, and the audience also can join.
Excellent case, Siddhartha. I think it's most important to understand that the main cataract surgery all of us we can do. The most important in uveitic cataract is how is your pre-op inflammation control and how you can control the post-op inflammations. Two quick points I just want to highlight. The two cases you have to be very careful even if the patient is quiet for last 3 months also. One is HLA-B27, another is VKH. These are the two cases if the patient is not on any kind of immunosuppression and the eye is quiet for even for 6 months also. Be aware that you need to start some oral steroid, at least wait for 1 month before you go for cataract surgery, because these two entities are known to throw very bad inflammation after cataract surgery. Sometimes it can clog your entire visual axis and result into fibrin formation, membrane formation over the IOL. So it's always better to take care of that. Two warning signs for before you operate a case of uveitis is one indication is that if the patient is having extensive synechia, and the second is if there is a history of cystoid macular edema in the past. So these are the cases you have to be very careful. And sometimes if there is a history of cystoid macular edema, it's important if there is no contraindication, IOP, or patient is not a steroid responder, you may have to inject a Ozurdex also to reach the desired level.
Great, thank you. Dr. Amitabh, your viewpoint, he's an inflammation expert from Kolkata. Microphone, please.
Mike.
In the meantime, Dr. Partho, you said about steroids in the preoperative period. What is the period, how many days before and for how many days? The oral steroid?
Yeah, it's always better that two condition, a VKH and HLA-B27. It's better to do a oral steroid for a little longer time if the patient is not on any kind of immune suppression, because if there is extensive synechia and all, and 3-4 days of steroid may not help in such conditions.
So you prefer a month?
Yeah, it's
Okay.
a month.
Okay, Dr. Amitabh.
So the baseline for any cataract surgery in uveitis is the eye has to be absolutely quiet. There's no compromise on that. If there's a flare, it's fine. You can still go ahead with surgery, but there should be no cells in the anterior chamber, or there should be no active inflammation, as Dr. Partha said. And there will be a couple of per-operative challenges, which Dr. Siddharth Ghosh has covered very well. In my hands, I've found the pupil expanders, the Grieshaber hooks, to be the best because they cause the least amount of damage. I don't really like using the Kuglins hooks, or I'm not really sure, I haven't used the Bhattacharya or the Malhugen rings, but it does not take a long time. It's just that you have to make four side ports which are extra. You can use the 15-degree blade itself to make it. And the other thing is the intraocular lens should be in the bag. And I think the lens of choice is hydrophobic acrylic IOLs. And post-operatively, you have to put the patients on steroids in a tapering dose. You might need, many of these patients might need non-steroidal anti-inflammatory drops as well, especially if they have had cystoid macular edema in the past. And the most important thing is to counsel the patient, because you have to give them realistic expectations, because if they have spent money, they might want a vision as good as a normal cataract surgery, which may not be possible all the time. Thank you.
That's great. So any questions from the audience? Yes? Quick. And I would request Dr. Ayan Mohanto, the next speaker.
Partho,
Partho has something?
you said,
On your-
as Siddhartha also mentioned, that it should be ideally 3 months we need to wait. But many a case, practically what we see, the inflammation is not taken care, the cataract is increasing. There is bilateral cataract. In those cases, would you advise to do a cataract along with Ozurdex implant?
Certain cases, doesn't require any steroid. For example, Fuchs uveitis, no need to go for that. VKH patient, yeah, sometimes you can combine it with this Ozurdex also, but the only problem with that is VKH is a multi-system disease. So if there is some recurrence of inflammation, you have to control it, all these things, because so many organs are involved. So that is important, number one. And yes, Ozurdex can take care of that, but sometimes you don't know whether these patients are steroid responder or not, because suddenly they have come to your hospital and consulting you, you don't have a proper documentation, and injecting something which you cannot take back. I think it will be, you have to be a little careful that directly injecting going for a Ozurdex.
Thank you. Dr. Anil Mondal, our
An
expert.
important consideration in the preoperative evaluation should be, is there any associated glaucoma? Most of the cases will have some rise in intraocular pressure. Proper evaluation should be done, and in borderline situation, probably if the patient is very well controlled with 1 to 2 medication, probably simple cataract operation should be okay. If the patient requires more than 2 medication along with systemic anti-glaucoma medication in the form of systemic carbonic anhydrase inhibitor, probably you'll have to decide for triple procedure versus simple cataract. As has been told, very rightly emphasized, lens should be in the bag. The type of cataract operation, phacoemulsification versus any other surgery. I do not think that phacoemulsification is the only way to go. In a difficult situation like this, probably one can go ahead with manual small incision cataract extraction. No problem. The outcome may be, in the early phase may be little different, but in the long run it doesn't matter. And in the post-operative evaluation again, the inflammation control, the level of intraocular pressure should be controlled, and all these things should be preoperatively discussed with the patient what should be the realistic outcome in an individual case.
Thank you. Thank you. So we have our next speaker, Dr. Anmant. You want to say? Okay, Dr.
Just
Subhadra.
one point that you can have uveitis cataract with hypotony. These are very difficult situations because you need to really do a UBM to know why this hypotony is there. Because if there is ciliary membrane and you inject Ozurdex, then you've created disaster. So you can't just take a cataract and say, so I've seen, giant retinal tear where the whole retina is folded up on the disc and you didn't realize there's a RD behind because it was a stickler with cataract and uveitis, and so the other eye could give the clue. So I think more than, of course, controlling the inflammation, the proper diagnosis, pre-op, even if that takes 1 or 2 visits. We have seen oculesmic syndrome, masquerading as a uveitis cataract. So if in an elderly you see some cells, then you should think what's the etiology. Just giving steroid and treating that cataract is not enough. You may have to do ARC before the surgery because they can have very subtle NVI or NVA. So I'm just saying that proper evaluation of history, evaluation, and taking your time. There's no emergency. Taking your time to think through that case. They are very difficult cases, challenging cases. Sometimes you have to do cataract surgery with silicone oil injection to counter that hypotony. So I think, taking help of your retina colleagues, because I'm from retina side, and discussing the case makes a huge difference.
Thank you. Thank you, Dr. Subhadra Jalali. So, see, there are a lot of inputs, you just can't be a run-of-the-mill surgery. You can't be dictated by the patient, sir, karna hoga, kar do, nahi hoga. You have to wait. So, over to Dr. Aran Mahanto. Very interesting, high myopic cataracts. High myopia is going to be very, very common in the near future. So, a seamless journey with advanced technology, a topic.
Thank you, Shubhashita, and thank you, OSWB, for giving me this opportunity. So I'll be, over the next few slides, we'll be talking on technological advancements which are helping us to navigate with very high myopic cataracts. So I have no financial... So I have no financial interest to disclose. So these are some of the issues which should be taken care of while we are taking up a high myopic case. Like number 1 is biometry. Number 2 is lens choice. Number 3 is anesthesia. Then capsulorhexis centration and dealing with LIDRS. That is lens iris diaphragm retropulsion syndrome. So with the advent of optical biometry, ocular measurements are now very simple, quick, and more precise. And this is ideal in cases with extremes of axial length. Why so? Because in myopic cataracts, if we do an ultrasound biometry, you are picking up the data, maybe you are not picking up from the fovea, you might be picking up from a staphyloma and end up in a refractive surprise. And these are the newer generation formulas, which is another technological advancement in which we can see that Barrett and Olsen formulas are fairly accurate in all ranges of axial length starting from 21 millimeter to 28 millimeter. So these are the 2 lines which are almost within 0 to minus point and plus 0.25. So those are the most accurate formulas and precise formulas for high myopic cataracts. Now regarding choice of IOL, myopics usually have a very good near vision. When we remove the lens and make them emmetropic, they have some amount of difficulty for near. So the target refraction for distance should be minus 1 to 1.5, especially if there is a macular pathology. And the IOL material should be such that it induces the least amount of PCO. And it's better to avoid trifocal lenses in axial lengths more than 30 mm. Topical anesthesia is preferable for obvious reasons because while doing peribral anesthesia, we can puncture the globe, leading to catastrophic complications. Capsular axis size should be adequate. It should overlap the optic, not very big, in which the IOL pops anteriorly, leading to more myopic shift or PCO formation, and should not be very small, leading to capsular phimosis. It should be perfectly centered, and if not, then there are chances of PCO formation. Flax may be helpful. Now coming to LIDRS, high myopic eyes tend to have deep anterior chambers, often accompanied by weak zonules, thin posterior capsules, and a partially liquefied vitreous. So you should lower the phacoperimeter to avoid fluctuations in the posterior capsule. A second instrument can be put in place to prevent contact between iris, lens, capsule. So with newer machines, we can, with active fluidics, this again becomes a cakewalk. Like see in older generation machines, when we used to enter the anterior chamber, the whole lens iris diaphragm used to go back, deepening the anterior chamber, and see the iris plane is hardly visible. So this is LIDRS. It can be overcome with a second blunt instrument. Just lift up the iris, and the pressure between the anterior chamber and posterior chamber becomes equal, and the LIDRS thing breaks. So while taking out the phacoprobe, do not forget to inject viscoelastic in the anterior chamber. Otherwise, it might lead to severe catastrophic complications. It might lead to retinal traction and tear. So again, in this particular case, you see with a newer machine, when we are entering the anterior chamber, look at my IOP at 25 to 30 mm, it hardly causes any change in depth. So this is another thing which is very helpful, which has helped us a lot to operate these high myopic cataracts. Look, there is no change at all. Thank you very much.
That was very insightful, Dr. Ayan Mahanto. Before I go to the panelists, I would like to ask you a question. See, in biometry, you have impressed us that it is required to do a scan before deciding, because they might have. Now, when do you actually go for this A scan? Which level of myopia? When do you start?
A scan or B scan?
B scan, sorry.
Yeah.
A scan we are doing for biometry, so you follow.
If you don't have an optical biometer and you are having fluctuating values with your ultrasound biometry, you should go for ultrasound biometry. You should go for USG and find out if there is any retinal changes that is leading to these erroneous results. So in optical biometry is fairly accurate. You can get a fairly accurate value all across.
And do you always target -1 or 1.5 for all types of myopia, or is it higher?
With macular pathologies.
Okay, only with macular pathologies, not for
Otherwise,
high
minus 0.5 to 0.75 is fair enough.
So it's near emmetropia.
Yeah.
Because we sometimes know that, as you said, there's a myopic shift. So do you target?
Myopic shift in case of, if your capsular axis size is bigger, then the lens tends to pop out of the bag, and
If there is a very deep
AC,
very deep AC.
Your axis size, because another important thing is doing a rexis is sometimes difficult.
Yes.
Because the chamber depends, you think that you are doing a small rexis, ultimately it ends up with a bigger axis.
Yes. So that is taken
It's
care
because
of.
of the magnification factor of the cornea.
Let us take some discussions from our panelists also. Ma'am, you would like to discuss this topic? Add your inputs on this?
Yeah, I don't do cataract surgery. I am only talking to the patients before cataract surgery. So a couple of concerns that whenever I have a high myo patient and somebody has done cataract surgery, the patient comes back very unhappy because they have not been told that now their life will change. They were using without glasses for near, things were magnified, and now they've been given distant vision very good, but for near they have to use glasses, and this was not explained to them. It could have been different. There could have been a different way of putting the IOL. But discussing with the patient is very important about their work and whether you're going to correct them for near or you're going to correct them from distance. That's very, very critical. Second, the type of myopia. Again, because I deal with a lot of children, so we have lenticular myopias, especially in ROP. It is not a axial myopia. Sometimes they have mixed myopia. It may be just index myopia. And of course, if it is an axial myopia, especially in children, then Stickler syndrome, I have to be very sure that this is not a case of Stickler syndrome. Because there the whole ballgame is different. They need very proper evaluation. And in many of those cases, I do a lensectomy with intraocular laser and vitrectomy rather than putting an IOL, and then they really get very bad detachments. So I think some of the consideration, again going back to the history and the diagnosis. Myopia is not one diagnosis, it's many diagnoses. And especially if you're going to correct one eye and the other eye, because we do RD surgeries, then they get cataract in that eye, the other eye has no cataract. Now what are you going to do? They are having -10 in one eye, and now they'll have +0.5 or -0.5 in the other eye. So I think these are difficult situations where, is he going to be monocular, is he going to use contact lens? And cataracts and myopia, again, other group is the syndromes. Myopia, cataracts are a part of many syndromes, whether it's Down syndrome or it is, our coloboma eyes. So in those cases, what type of surgery has to be done? Has it to be a lensectomy with vitrectomy, or it has to be a surgery for IOL, and what are you going to do with the PC? Because if they get a PC, then you're very always concerned about doing a YAG. So what type of treatment you're going to do for that? I think these are some of my concerns when I'm advising myopia cataract surgery.
Ma'am, since you talked about the retinal part, when would you advise a cataract surgery if you have done a retinal laser or retinal procedure after that?
So there are two groups of patients. One where vitrectomy has already been done, silicone oil removal or gas removal has been done. These are already vitrectomized eyes. We are fine. The surgeon should know that the AC will become, deep, and it will be. There may be a zonular dialysis or there may be a PC break already there. So in those cases, they can go ahead and do cataract surgery after 1 month of the retina surgery. Okay. There's no issue, but the surgeon has to be experienced in knowing that there are challenges when they do the cataract surgery. If we do laser for the prophylactic laser before surgery, so these patients usually, we say 1 month, but the 2 weeks is also fine because the laser is expected to finish their job by 2 weeks. But to be on the safer side, usually we say after a month.
Okay. Thank you. We have
and
high
then
volume.
Post-op, of course, the post-op care that they need periodical examination, whether it's a refractive surgery or cataract surgery. They need periodical retina examination, and that should be labeled in your file. Because what happens many times, they have already had cataract surgery done, but nobody is recording that this is a high myopic eye. Same for glaucoma, refractive surgery. So that in your file, that this is a high myopia patient who is now emetro because of cataract, that they need lifetime of retina checkup, not only for lattice but also for CNVMs and other things. Glaucoma, they can get normal tension glaucoma, very common.
Two things are very important during the surgery. First is that AC becomes very, very deep. Even with the active fluidics nowadays, you have an IOP of 20. Sometimes the 20 itself is very high, and there is no way you can reduce it. So that's we are all doing now under topical. The patient feels the pain, very too much of pain, and that is one issue. And the iris becoming shallow, small, and bellowing of the iris. This becomes a problem. So you have to come out and put viscoelastic and then do again. And the more the time you go introduce your Veco, the more the pain patients will feel the pain. That is a real issue.
That's right. That's where IOP ramp, I think something called IOP ramp comes in, 2 seconds, 3 seconds we put. Anyway, Dr. Arup Bhomik,
yes.
You've got some,
high volume.
You're a high volume
Cataract
surgeon, tackling a lot of myopic cases. Your inputs?
Arup, come in front, come to this one.
This one is working.
This is working. So, luckily, madam said all the difficult cataract surgery in the myopia, childhood myopia, having a retinal detachment. Lucky enough that our retinal surgeon do a lot of cataract surgery. And so, in our case, myopic patient, we advise if you have a bilateral cataract, even one eye advanced cataract, one eye very less cataract, we advise them to try to consider the cataract surgery consecutively both eyes, so that they will face the less problem. Because anisometropia in between the surgery is a very disturbing. So even if you one eye has a -6 and you correct it and you make a 0.75 in other eye, so it is very difficult to adjust this sense. Then we will tell the patient you may delay it for 3 month surgery, but whenever you decide your surgery, try to decide your surgery very quick both eye. This is the one tip. And another, that's the surgical part which is very common. Trying to do a rhexis, always you end up with a larger rhexis in the myopic patient, because we have an impression to see the limbus or pupil as a guideline to do a rhexis. So please look at the Parking's image and do the 2.5 or 2 millimeter another package image, and this is the one tips I can give you. Thank you,
Great.
sir.
That is why you use the, capsulorhexis marker, maybe.
Yeah,
Anyway,
I use-
thank you. So we have our next speaker,
Yes, Dr.
young
Vijit
Dr.
Mitro.
Arijit Mitro, a glaucoma expert, to speak about initial baby steps of phaco with MIGS. Over to you.
Great. Thank you. Thank you so much. So my topic is titled The Initial Baby Steps of phaco with MIGS. So the MIGS wave is here. So if you want to ride it, you've got to learn how to do it. So, and the good time is now, because we don't know what the future of MIGS is, but at the moment, it's definitely a hot topic. So, regarding the initial baby steps, the first is the microscope and the patient preparation. Now, that's very, very important and key to doing a good MIGS surgery. So, we are all using, either a Lumera or a very high-end microscope. So, what you've got to do is you've got to mark it, because the positioning of the microscope and the patient is very, very important. So during MIGS, you've got to tilt the microscope towards you. You've got to tilt the head of the patient away from you. So the microscope is yours, so that has to be tilted towards you, and the head of the patient has to be tilted away from you. So what you can do is you can use an app to mark the degree of tilt, so that next time you don't have to do it. You just got to align it, and then you got to push the head of the patient away from you. So, the tilt is a 30-degree tilt of the microscope towards you and a 30-degree head tilt of the patient away from you. Some say it's a 30 towards you and a 40 tilt of the head away from you. Some say it's a 30 towards you and a 45 away from you. But it's more about doing it. So you got to reduce your chair height way below the normal phaco surgery. So you reduce your chair height, tilt the microscope towards you, tilt the patient's head away from you. Otherwise, you're not going to get the en face view of the angle. Now, once you've achieved this, you've got to enter post phaco and try to bring the size of the pupil down. Because during cataract surgery, we all say, pupil ta choto kano. Here you want the pupil to be small. So, but the moment you use a viscoelastic, so here what we prefer is hyaluron, which is 1.4% sodium hyaluronate. Now once you inject viscoelastic, immediately the pupil is going to dilate again a little bit, but that's not going to hamper it. You've got to put a blob of the same viscoelastic, and then you're going to use a gonio lens. Now, there are these 4 gonio lenses which are currently in vogue. One is the Swan-Jacob gonio lens. Now, that costs around 1,25,000. So, if you have it, it's great because it's a one-time investment. You can autoclave it and keep on using it. The second is something called the iPrism SX. It's a very small instrument. It's made of PMMA. And ideally, it's disposable after every case, but you can easily use it for 15 to 20 cases. So that's what we are doing it. Make sure to wash the viscoelastic off, and then you can e-to it and keep on using it. The third is something called the Moria ocular gonio lens. Again, that's extremely expensive. That's more than 2 lakhs. And the fourth is something which is a hands-free, just like a biome. You can attach it. That's from Oculus. It's called Oculus Gonio Ready. So you don't need to, you'll have both your hands free. Now once you have either of these, you can fix it and you've got to tilt the head post-phaco until you get this particular en-face view. Now, once you get this en-face view, after every phaco case, try to use a spatula and just touch the trabecular meshwork and come out. So that is all you've got to do for your initial thing. So you can either try a lateral movement as if you're stripping, or you can just touch it and come out as if you're doing a stenting. So any of these two procedures. So here, I'm kind of going, touching it, and I'm trying to practice, doing an eye stent, or I can just, make a lateral movement. So these are some of the initial cases that I used to do. After every phaco, I'll go back in, I'll put viscoelastic, and I'll try and just touch the trabecular meshwork and come out. So this is a very good way to learn, A, how to get the view, B, your hand movements, because you're going to land in a soup if you start doing it suddenly. So there are these 4 MIGS procedures which are now in vogue. First of which is extremely simple to do, that's called a bang. So all you need for this is a 25 gauge needle or a 24 gauge needle. You bend it so that just the tip is bent. You don't have to use a lot of force. Remember, it has to be very gentle. So you can just try and strip even a little bit. So you can see you can see the tip. You don't have to go deep. You're going to create a false passage. So you may have these initial hiccups, but once you do that, you'll see a very clear whitish patch showing through. That is the end point. You don't have to go on stripping it. It's just a very gentle strip. That is all you have to do. So initially you can try just for 90 degree and leave it. Nothing is going to happen. And then gradually increase to 120 and, go on increasing it. And put a viscoelastic so that you can see that white zone. That is all you need. That you've stripped the trabecular meshwork off. So, it's just a very, very gentle strip. And as you, keep on doing it, I'm sorry, that is kind of blocking the view. So, it's just, so this is the 3rd or the 4th case. So you just a gentle strip. Now, once you're very comfortable with this, you can shift to something called the KDB. So this is a very wonderful instrument. The advantage of this is that it has a tip and it has got these ramps. Now, the ramps are cutting blades which can be used to, make a very clean strip. So if you look at it, you just introduce the instrument, and again, here you can see blood in the Schlemm canal. So you just strip it. It's a very gentle strip. So here, I've just stopped it midway to come out and just show you that white colored area that you can see. So it's a very, very gentle strip. So once you're proficient with it, you can go from one end and you can just strip the entire, 120 degree or even further with just one go. And it cuts very smoothly, like knife through butter. And again, you'll see that very clear white strip. Now, once you've completed that, you can move on to the eye stent. So I'll just, 1 minute, I think. So this is it's an extremely expensive instrument. However, the West Bengal Health Scheme and the CGHS, they've approved it. So you can start doing it. Initially, you're going to have a problem with the view, but the instrument, I borrowed a video from Tanya. So you can see initially, you just have to introduce it. It may bleed quite a lot. So be very fast in doing both one after the other. If you wait, as in this particular case, you'll see that, post, now this is the video which I borrowed from Tanya. You can see the trocar. The eye stent is threaded onto the trocar. You just push it and it goes and it gets delivered. Yeah, and the last but not the least is another video which we currently in West Bengal are not doing, something called GATT. Again, it's very, very inexpensive. You can take a polypropylene suture, mushroom the head with a cautery, and then you make a nick into the trabecular meshwork, and you can use a Grisheber forceps to introduce it. You can see the mushroom tip. Be very careful because it can create a false passage. So this just goes in 360 degree. Again, it looks very simple, but this is probably the hardest of all the 4. So you just keep on this continuous motion comes out through the other side and you can strip it off.
Beautiful
Thank you.
videos. Thank you so much, Arijit. So just tell me, what is the learning curve? What is the learning curve of this procedure that you said?
So I think the primary learning curve would be to position the head of the patient. So that takes a lot of doing, especially for people who are not doing gonioscopy. So that is going to take a month or two to get adjusted to that. You do the last couple of cases of phaco and then try to do that. Once you do that, a bang is a very, very easy procedure to do. So maybe within 3 to 4 months, you'll be able
If
to
one does
get
not
ahead.
want to buy those prisms or lenses, so how do they get them for practice?
That's a tough question because
That's a tough one. Okay.
the eye prism SX is relatively
I think
cheap.
we
That's
have the
5,000.
master here, Dr. Anil Mondal.
Mondal, sir.
Please.
Arijit, I have a basic, confusion, controversy about mixing phacoemulsification with minimally invasive glaucoma surgery.
True, sir.
The very idea of minimally invasive is the least manipulation intraocularly.
Correct.
When you are doing phaco, I don't see any reason that it has to be, glaucoma surgery has to be minimally invasive, because the most invasive surgery you have done already. However, there are several advancement of this kind coming, but it has to be evaluated against the standard surgery of phacoemulsification with trabeculectomy. So those kind of authentic reports are still awaiting in the literature. Unless those comes, we really cannot tell. However, whatever Arijit has presented is an elegant technique. Glaucoma surgeons should learn it and then plan about their management.
Dr. Manish, your comments?
I think Arjit has already highlighted the very important point that more than the actual surgery, the visualization is something we should take time, try to practice it. In fact, most of our cases where we have complication like too much of bleeding or a cyclodiasis cleft we created or we injured the ciliary body, the primary problem was poor visualization. So if you have a good visualization, but I agree to Mandal sir, we still don't have enough data of making patients spend lakhs of rupees for maybe 2 millimeter of extra IP reduction. So we still need more, but I think Arjit what has highlighted, bang is a very good procedure, totally cost effective, and it's actually quite useful in certain patients, so it can be tried definitely.
Well done, Arijit. Thank you.
Thank you.
With that, I think we have come to a very interesting thing in this quiz, in this symposium. There's a quiz planned for the audience. So everyone, I think even the panel can have that, and the chairpersons.
Yeah.
So over to Dr. Sugata Paul and Dr. Anujit Paul. Paul and Paul.
Yeah, only prerequisite is to have a pen to write. আচ্ছা তো quick এখন আর টাইম নেই লাগবে তো
So, on the piece of paper, please write your full name, your AIOS number, and most importantly, your phone number. If he cannot contact you, you get no prize. The prize comes back to the quizmasters. Okay, number one. Rule number two is, as in all quizzes, the quizmaster's rule and decision is final, so please don't look at us if the answers do not match. You will get 5 seconds for each answer. The question will be displayed for 5 seconds. There are 10 questions, so please write from 1 to 10 all the answers. AV team, please put up the slides.
Slides.
Once again, name, AIOS number, phone number, 10 questions, 5 seconds each. Please stop talking and we will begin now. Question number 1.
Paper, any paper?
There is a Hess chart in front of you. Please mention the diagnosis. You have 5 seconds. Please mention what the diagnosis is. Okay, and 3, 2, 1, next question, 5 seconds for the next question. There's a color fundus photograph of a 56-year-old male given below. Right eye best corrected visual acuity is 636, left eye 612. OCT shows a subretinal hyperreflective deposit seen in both eyes with hypertransmission and lesion in the right eye. Question is below. Mention the gene responsible and what are the specific electrophysiological investigative findings. Gene responsible and findings. 3, 2, 1. Right. So now next, not that. Please don't tell your answers out loud, sir. Question number 3. There is a pentacam image in front of you. Identify the condition. Please mention the name of the condition from this image, and please mention the sign that is involved. Retina specialists, please take help from your non-retina colleagues. This is the time. 3, 2, 1. Time for question number 4. A 2-year-old child presented with esotropia and leukocoria. HP examination of the lesion is in the image. Name the specific finding on histopathological imaging which leads to this diagnosis. We won the name. We just won the name. You have 4 seconds. Please remember your pathology now. 3, 2, 1. Last question. Another googly for everyone. Apart from eye movement, what other test is done here? Name the test and the diagnosis. Name the test and the diagnosis.
Hey.
No cheating first benchers. Right. 3, 2, 1.
Yes. 5. So I'm going to the next question. Quick. Next question. How many locations are tested in 10-2 program of HFA? Manish, তুই বাদে সবাই answer করবে. 5, 4, 3, 2, 1, 0. Next question. Which tonometer is being used here? 5, 4, 3, 2, 1, 0. Manish, prize পাবি না. This is World War II aircraft. What gift of sight they are related to? ঠিক আছে. So next question. The eyes at the window to your soul. Whose quote? 5, not mine, yes. 5, 4, 3, 2, 1, 0. And the last question, and then we'll collect the answer script. What connection of migraine with Alice in Wonderland? Alice in Wonderland, written by Lewis Carroll, I believe. What is the connection of migraine with the book? 5, 4, 3, 2, 1, 0. So with that we end the quiz, and can we just exchange and correct? Please exchange the answer script. So we'll give the answer now, no? It will take 5. So we'll give the answer now. Achha.
You have got all the answer scripts with you. You have got the phone numbers, and you have got all the answers. Only thing is that you can give the answers here. Shugata Paul, if you are ready, or Anujit, you can give the answers. Just go through for.
Sir, let it be at the end.
At the end?
Let
Okay,
us-
at
let
the
it be
end. That's fine.
We have our next speaker. This
Fine.
is diabetes with retina. And the first one to go is Dr. Mukesh Jain with his topic, Cataract and Diabetics. Be proactive, not reactive. All over to you, Dr. Mukesh.
Good afternoon, everyone. Thank you, OSWB, for the opportunity. Can I have my slides here? So the topic of my presentation today is be proactive and not reactive when doing cataracts and diabetics. So I do have a conflict of interest here, and that is that my presentation is from the perspective of a retinal surgeon and may look overwhelming to others. So first question that we need to ask is, are the cataracts and diabetics different? Yes, they are. because these patients are relatively young. They have softer cortical cataract or PSC with poor pupillary dilatation. They have other diabetic eye disease like diabetic retinopathy or glaucoma. They would have underwent multiple anti-VEGF injections or vitrectomy and have multiple systemic comorbidities. You name them and they have it. So how does being proactive mean? It means we need to be proactive before surgery, during surgery, and after surgery. So during pre-op, we need to plan ahead. We need to be very careful when we are planning this surgery. Apart from the routine cataract examination pre-op, we need to have a more holistic examination here where we do a BCVA correlation with the findings that we see. We must carefully look for NVI and NVA in the undilated state. And we must be very careful to see the periphery and not just screen the macula to know the DR status. And look for other comorbidities like glaucoma and cornea. And OCT macula is now a common investigation pre-op, but may require an FFA and OCTA sometimes. You may have to do a biometry correction based on the macular status. And please do not forget the other eye, because there are many clues that we can get when examining the other eye. Manage systemic comorbidities. Ask history, take time, know the control, the medication, understand the myths and beliefs. Take it as an opportunity to screen for other comorbidities. It develops trust. Educate them for better control, not just for surgery, but for a better healthy life. And we need a sugar below 200, but most important, do not push your patient to get it controlled very quickly, because it can lead to rapid deterioration of systemic parameters too and of diabetic retinopathy also. And most important is to develop realistic expectations. You explain them why the cataract surgery has been done. Is it to improve vision or to facilitate your PRP? Make them understand that this surgery is not like to be their relative surgery where they have received 20/20 vision. Discuss the complications in a very subtle way and also address the need for additional treatment if required in future. Cataract surgery is pro-inflammatory. It means that it has been shown in a recent meta-analysis that after a cataract surgery, there are a substantial portion of people who can develop sight-threatening complications. And if you have a patient who are moderate or less, it is unlikely, but patients who have severe NPDR, they are likely to deteriorate, so you must stabilize them, ask for a retinal consultation, and get it stabilized before you do the cataract surgery. If you have a DME, better to do it prior to it, but if not, you can do along and a steroid or anti-VEGF injections. If you have a PDR or complicated stuff, we have the next talk for it. So what do you do in intra-op? You need to have good skills, execute well, but always have plan B and C ready with you. You have to manage pupillary dilatations. You avoid small capsular excess and avoid multifocal IL because it will make the retinal visualization difficult. Always anticipate a risk of PCR, especially if the patient had underwent multiple anti-VEGF injections or a vitrectomy, and be ready for it. Take time and clean the cortical fibers. It helps in peripheral visualization as well as reduce the risk of PCO. And always give an intracameral antibiotic because the risk of endophthalmitis is higher. Once you have done the cataract surgery, don't think the war is over. Be vigilant. Any untoward inflammation, always think of endophthalmitis because these patients have an immune compromised state. A risk of CME and DME is higher. You can give a perioperative NSAIDs, OCT and refer as required. DR reassessment is very important, as I have already said. In case of severe NPDR, they can progress faster than usual. So you might require a more closer monitoring, and the follow-up duration need to be decided case to case, not any individual one. So finally, the take-home message from my presentations are, complications are not uncommon in these situations, but excellent results are possible. Be proactive, plan ahead, execute well, and be vigilant. And finally, cataract surgery is just a chapter in the book of diabetic eye disease. So always be vigilant and make them understand that it is just a part of their journey and they need to follow up with you or your retina colleagues throughout life. Thank you for your kind attention.
Thank you. Excellent talk by Dr. Mukesh Jain. Before we go to our experts sitting on the dais, can I request, be proactive? I think Dr. Shubhankar and Dr. Arnav, they are both heading institutions like railways departments where you have to take maybe most of the major decisions in these type of cataracts. So what is your experience in diabetic cataracts one by one, please?
Yes, no doubt the incidence has gone up so much these days that, and every OT you have quite a few of them. So, few things we always try to do in these cases is the choice of IOLs that we use. We never would give them any multifocals or a bifocal IOL in these cases. It's just either a monofocal or even the extended depth of focus IOLs. A proper rexis is so very important. A proper centered, good rexis is what we also advise all our students as well. That these things you need to do, and definitely an OCT prior to surgery is so very important. Even if you see what you visualize the retina while doing a fundoscopy, that it's fine, but still it's preferable to get an OCT done. And as he said, inject before the surgery, or if you want to do it early, do it at the time of surgery, even if there is a little bit of macular edema. I think,
and that's it. Most importantly, you've got to spend the chair time with the patient. Dr. Home?
Another thing Arnav has pointed out, absolutely correct. But one thing is that I think regarding the central rexis, and the rexis should not be small. I think for post-op, I think for treatment of retina, I think it should be educate enough, and the lens should cover. It should be a large, comparatively good optic. That is one point I think is clarify. And regarding, we prefer that for the compliance of the patient and other things, if needed, we in the same sitting we give intravitreal injection. If required in these cases, then call them after 1 week or 2 weeks later. It's better if needed.
Thank you. Dr. Shubhadra, please.
Thank you, Mukesh. I think that was excellent. Just a couple of points. One is that these diabetic patients are also prone to epiretinal membranes, silent epiretinal membranes. So when you do OCT, you might find a thin ERM. So these don't need treatment. And so many patients come to us, should I undergo ERM surgery? Should I not? If they're asymptomatic, there's no metamorphopsia, we don't need to tackle that. Okay, although you may pick it up on OCT, it doesn't need handling unless there's a vitreomacular traction. So of course, in those cases, you will take help of your retina colleagues. The second thing is NAION. Now, NAION is not uncommon in diabetics, and we know that cataract surgery can precipitate it. So there are certain precautions you need to take. Of course, during your initial evaluation, you will look for disc at risk, which we have, Swan Singh Harris has described as small discs without cup. These are the highest risk. Of course, normal discs can also get NAION. So what are the precautions? Avoid hypoglycemia. So take it as the first case or second case in the morning so that they are not waiting. Avoid hypotension. Again, because of dehydration, summertime, that is very important. And during your surgery, there should be least fluctuation of your IOP, because a hypotension during surgery is another risk factor. Of course, if you're doing their pre-op evaluation, if you're seeing a disc at risk, get the ESR done. If ESR is high, they need treatment before you take up for cataract surgery. And those who get NAION in one eye are at very high risk of NAION in the other eye during cataract surgery or soon thereafter. So this is a group that you need to be proactive, find these patients and take the precautions. Also, vitamin D levels, it has been found, of course, in general for all thrombotic events, homocysteine. So these are some of the risk factors. Once you see a disc at risk, make sure these things are taken care of. And recently controlled diabetic, sometimes sugar is 300, 400, we control diabetes, and in 2 days we do surgery. This is a little risky because their body has still not reached that milieu where they are, the sugar has come down, but the body is not ready, so there's no hurry. You can wait for some time, and then maybe after a month or so, rather than just, control it and then do cataract surgery. So these are some of the precautions. And of course, there's no substitute to looking for NVI. NVI can be very subtle. If there is an NVI, so very subtle, or an NVA, and you have done cataract surgery, they will present in a week or 2 weeks with endophthalmitis-like picture. And they will look like endophthalmitis with, pain and low pressure, and then the pressure will go high, and you'll see a hypopion. And you will inadvertently treat them for endophthalmitis, and after 3 weeks, they'll come back with full-blown neovascular glaucoma. So this entity has to be thought of. If you think preoperatively, the retina looks very featureless, and tessellate it. Get the carotid Doppler done. Look for NVI properly. You will find very subtle NVI very soon. So of course, I like to do ERG for them to pick up the ocular ischemic syndrome, but carotid artery disease is a accompaniment of many of these patients. So past history of strokes, MIs, any other vascular events, amputations. So these are the patients who would have risk of carotid artery disease also.
Thank you, ma'am. Yes, you got a question?
Presently not, but previously about 30 years back, there is a term associated with cataract surgery that was PBHI, peripheral buttonhole irectomy. Presently not, but in diabetic patients, we must be alert that peripheral iris, it is neovascularized. It should not have any trauma by any instrument or the phacoprobe. Sometimes it harasses.
Okay. So, anything else? Anyone? Okay. So, we go on to the next speaker, the last one. And I think we have got good time on our hands. We got 15-20 minutes late, but
Really, we have our quiz.
yeah, but that's okay. The last speaker, Management of Advanced Retinopathy in Cataractous Eyes. Dr. Dev Dulal Chakraborty, please.
Thank you, OSWB, for this kind of opportunity. I'll be speaking, like sir mentioned, Management of Advanced Diabetic Retinopathy in Cataractous Eyes. A lot of this has been actually taken up by ma'am, Shubhadra ma'am, and we will just, kind of follow up with the discussion. So diabetics with retinopathy are more prone to develop cataracts, and it's not always that you have, soft cataracts, you can have hard cataracts too. Now, poor glycemic control, younger age of the patient's onset of diabetes, longer duration of diabetes, associated diabetic retinopathy, diabetic macular edema are the most important risk factors for occurrence of cataracts in diabetic patients. Now, we have to actually decide whether to go ahead with the cataract surgery first, how hard is the cataract, and also figure out how is the retinopathy status. Now, most of it can be managed by comprehensive ophthalmologists, and you don't have to refer all cases to guys like us doing VR surgery. So the IGO has come up recently with a publication where there's a nice flow chart. The bottom line is management of diabetic retinopathy with coexistent cataract depends on the retinopathy stage and the cataract grade. So let's kind of visualize a certain few situations so that you can take back home something. So many a times you will have post VR cataracts coming to you. Now these are hard cataracts. Very important to do a proper dilated slit lamp examination. Just don't go home thinking, okay, grade 4 kar denge. Because often you can have a shaft injury to the posterior capsule, and you have a drop nucleus during the surgery. Now let's take up this case. Female lady, 60-year-old, post VR, 636 partial vision with some macular edema which has come back after a previous vitreoretinal surgery. That was a vitreous hemorrhage removal some time back. So you can do this surgery carefully, of course, and all of you are good cataract surgeons, and just inject something. It could be your injection of choice. It could be a biosimilar, it could be a DEX implant, IVTA, or any anti-VEGF for that matter. Let's move on. So like ma'am mentioned, slight ERMs do not need removal, need removal. So in this patient, this is a post PRP scenario. You have some fresh vitreous hemorrhage here, some it's a hazy sort of a picture because of some cataract that's there. So here what you can do is you can do the cataract surgery. Again, take care to inspect the cataract very properly, and give an anti-VEGF or maybe a dexamethasone if the patient can afford, because anti-VEGFs can actually aggravate the ERMs, whereas dexamethasone will not cause any damage to the ERM. But if you are giving a dexamethasone, do a proper panretinal photocoagulation. Why dexamethasone? Because once you do the cataract surgery, the edema will be aggravated. Otherwise, if the ERM is not there, you can jolly well, for this mild kind of edema, you can give a biosimilar and follow it up with laser after 2 weeks. Now let's move on. Like ma'am mentioned, when you have a VMT of a similar kind of a situation, then actually you can go ahead with a combined surgery. If you don't have a VR surgery at your place, you can do the cataract surgery, explaining to the patient that you are going to need this subsequently, the surgery subsequently, and you can send the patient subsequently also. But if you have the opportunity, you can do a combined phaco vitrectomy with endo laser and IVTA maybe. And this is the result of this patient from 624. Patient improves to 69. I've done PRP here also along with the cataract surgery and the vitrectomy for removal of the VMT. And sometimes you have very minimal cataract. So be wary of doing cataract surgery in this kind of situation with this kind of a picture, because you actually when you see a DME, you have to do a OCT. Very, very important. If you don't have a OCT, you can end up with a situation like this: traction, lot of neurosensory detachment fluid here, and so it's very important to do a vitrectomy here rather than going ahead and doing the cataract surgery. So you have to remove the the vitreous traction, and of course you need to put in dexamethasone implant or IVTA at the end of the surgery, and of course don't forget to do laser. So this is something of course in the VR realm. Now sometimes it's a double whammy. You like ma'am mentioned, a lot of these patients have NVI. The NVI has not come out very nicely here. So NVI with a dense cataract, with you cannot see the fundus, and you have an ultrasound picture that says something like this, sort of TRD with multiple attachments, thick retina. So these are bad cases. So caution is advocated here, and you have to do a phaco with of course implantation with pars plana vitrectomy, IOL implantation with pars plana vitrectomy, and of course don't forget to do a give maybe anti-VEGF. So these are situations where this can be really testing, because this is a patient that I have done very recently, and these patients are kind of patients who have lots of morbidities. So you can see this shaking, which is actually shaking by the patient's breathing. So you have to be very careful while doing cataract surgery in these patients. And any maneuver, I'm doing a bimanual vitrectomy here, and these kind of small cauterization can in fact puncture the retina because the patient is moving. So you have to be adapting doing this carefully. But having said that, these patients actually do fairly well, because you can expect 636, 624 vision in these kind of patients if taken care of properly. So it's basically horses for courses, and depending on the situation, you can actually take your pick and do the surgery. Most of it can be done by a comprehensive ophthalmologist. Thank you for your kind attention.
Oh, thank you. So Dr. Anuruddha Maiti, your take on this paper?
Debdula, in the first case, will you not prefer to give an Ozurdex along with the cataract, because it will stay for a longer time and will address the post-cataract inflammation as well, instead of giving a biosimilar?
Absolutely, absolutely. But cost is a factor. So depending on that, my first choice would be a dexamethasone implant, or maybe IVT, or maybe biosimilar. But today we have long-acting anti-VEGFs also.
When there is a VMT, the VMT what you showed, I think it's always better to combine a cataract along with the VMT surgery, or rather do the cataract and wait for the complication to happen and then do the retina surgery.
He said it's better to do together.
It's better to do together.
Yeah. If you have
on the other hand, actually, the last case, when there is an advanced period, it is always better to deal the retina part, make it stable, along with the oil removal, if oil is given, do the cataract, I think, because it will prevent the neovascular glaucoma in those.
Absolutely.
Yeah, I think one thing very important to understand what you showed, patients can go into pulmonary edema and cardiac arrest very easily. They have multiple systemic problems. Putting an IV cannula before you shift the patient, that's very important. Having them been seen by a physician to know what is their comorbidity is very critical. Your team should have undergone, basic life support every day in our theater, because of course we are dealing with very complicated cases in a tertiary center, but we have handled pulmonary edema. You can lose the patient very suddenly. So the moment the patient, so we put a BP cuff, we put a pulse oximeter in all these patients. The moment the BP rises, patient is breathless, we stop the surgery. And that is one of the reasons why some of these patients we do a two-step surgery. Because when you do two surgeries together, the duration of surgery is very long. And for patient to lie down on the table for that time, so see the health of the patient, see how he is, don't do surgery. So I have had patients who when I'm looking at them, I think they're going to die in 1 month. They are having all puffy faces, they have proteinuria and all that. Madam, cataract surgery kar do, next month karenge. Next month I see their name in the newspaper. Okay, so they can die. Their systemic condition you have to evaluate when you have all these comorbidities. That is very important. And be ready for any eventuality, especially if you are a surgeon who was in the isolated clinic.
Yeah, that's a very good point. Another point, madam said ERM छोटा सा थोड़ा सा होगा. It's not a big deal for a cataract surgeon. And what about some intraretinal cyst? थोड़ा बहुत हो जाता है उसमें.
It's okay.
It's okay.
See, everything, I think it's very good to do OCT in all
Yeah.
your cataract patients. And, if you find some PD or some drusen or some ERM or even you sometimes you have a lamellar macular hole, to explain to them that there's something in the retina which may, hamper your near vision. But many of the patients, they do fine after surgery.
Okay.
But inform them that there's something which doesn't need handling now. The cataract surgery will be done. If your vision is good post-surgery, we only
Nothing
need
more
follow-up.
or later on.
Otherwise, it can be tackled.
So anything from the audience? Yes.
Just one query and just to know what others do also. So, as far as the blood sugar level goes, when do you accept it? It's something that they have done 7 days before, 2 days before, 5 days before, or the very morning of surgery. The second thing is that the AIOS guideline is 200 postprandial and 160 fasting. Frankly speaking, I do, because we are in an institution, I go up to 299. It's not 300. Telling the patient and their attendants the comorbidities, because we have seen cases where the sugar does not come down despite all therapies given by the endocrinologist. So what to do? Let the cataract get harder and harder and let the patient have other things getting into the eye, or we do it and then maybe control the blood sugar even better just after the surgery.
Everything depends on informed written consent. So what we do is follow the AIOS guidelines, but in a situation where we can't, say patient comes with 300 sugar and he has endophthalmitis, we can't wait. So if you are doing cataract surgery at 299 pressure, you've already tried 2-3 months to get the sugar, take an informed consent, explain that we are doing it with 300 sugar, there is some risk of cardiac problem, there is some risk of infection, but you have to be under proper care and there is a good chance everything will be over, but there is some risk. And take that high risk consent,
Is it necessary to get the sugar done that morning also?
We are doing it like what we have said within a 1 week of
If I can add, so coming back to your question, 2-3 things. One is, no matter when the sugar has been done, it's always important to do the sugar on the day of the surgery. Number one. Number two, all my patients I do only sort of post VR phacos and phacos which are not done by the usual. I'm leaving aside Oyanda, Orubda and big guns like Siddhartha, Rotizda here, Orubda here. But for routine cataract surgery also that comes to my OT, all patients are on, have a cuff, have a pulse oximeter, have a infusion cannula. Because like ma'am mentioned, last month I've had a cardiac arrest on table. So that was managed because these were there. Otherwise, we wouldn't have known that the line is flat. So it's very important to do your and be. I'm a conservative surgeon. Something goes wrong and the patient has 299 sugar. The court is not going to leave you. We had a OSWB session some days back, but it's very controversial to do something.
So it's
beyond
time we should request AIOS to come up with a different advocacy is needed. It should change, I believe. Okay, so here we are going to announce the results of the quiz. Within a minute this will end, and the answers to the quiz, and as the prizes we have got, what do you have? You have prizes?
Yeah.
Okay. They have got real prizes.
Yeah. So we'll
he has got something to say.
Yes, sir, surely.
One information regarding the blood sugar level. I've been talking to the diabetologists and other people. What they say that one isolated level is not enough. So one should always consider the HbA1c levels. If they are under control, well below 6.5, then only go for the surgery. And on the day of the surgery, one must always do the blood sugar level. So HbA1c control, and on the day of surgery, the blood sugar level. These are two important factors.
Sir, being a very good friend of yours, I beg to differ on this because about 10 days back we had a big session with the diabetologists, endocrinologists in Kolkata, the renowned ones. They said, "Abhi change ho gaya hai." You find out the American Diabetes Restriction website, you find out about the English whatever restriction they have got, and many such. They say 8, and the Japanese one says 10. So 6.5 nahi hai.
नहीं sir, हमको AIOS has to change that guideline.
Yeah.
No?
That
We
is
have
required.
to go by
AIOS needs to
so
be
please
requested
give
and
the inputs to
advocacy.
them. Yeah,
Yes,
please
you're
give the inputs to them because because
We
for
have-
us,
we have
we
lost time, sorry.
Because we have to follow what
We have
our
crossed
AI
time.
is.
Madhu, please.
So we'll quickly have the results. Everyone, please attention towards the screen. The answer to question number 1 is right eye lateral rectus palsy. Excellent to those who got it right. Answer to question number 2 is best 1G, normal ERG but abnormal EOG with Arden ratio less than 1.5. For this condition over here, I hope the retina specialist got it right. It is pellucid Marden degeneration with crab claw appearance or kissing bird sign. Answer to the histopathology question is flexor of intestinal rosettes in retinoblastoma. Answer to question number 5 is left superior oblique palsy. We are looking for a specific name, which is Belskowski test.
And for the next 5 questions, answer to question 6 is 68 points. Most of you got it right. Which tonometer? It was Draeger tonometer. Aircraft, all of you got it right, is the PMMA material. Whose coat? Mahatma Gandhi came up. Answer is William Shakespeare. And the last one, Lewis Carroll had migraine, which I said, but it was the micropsia which caused the during the migraine, got him to imagine the smaller version of the characters. So thank you very much. Anujit will be announcing the prizes. Sudipta has vanished with the prizes. No, you have.
Who thinks they won, please raise your hand. Nobody has won this very difficult quiz.
Yeah.
So in third position,
two prizes for the quizmasters as well, I think.
so prizes for joint third goes to Dr. Mukesh Jain and Dr. Pragati Paul. Please, let's have a huge round of applause. So we'll have both of you on stage for and prize for the second prize goes to Dr. Rajshekhar Paul. Wow. Excellent. So you never, and Shogota Paul, sir, you never know what's happening. We won't tell, you will never know. And finally, first prize, without surprise, goes to Dr. Shubhadra Jalali ma'am. I would request all the speakers and the panelists to please come up for a group photo, and then we would request the immediate next session to come up and take over the dais as well. Thank you.
I request our chairpersons to please hand over impromptu all these, and let's have a group photo. Please, everyone, please come up. Yeah, everyone, I said.